Joint pain can be due to injury and inflammation of the joint and wear and tear of the cartilage in the joint. The medical terminology for joint pain is arthralgia. Arthritis is a condition in which the joint is inflamed, leading to joint pain. Arthritis can be due to degeneration or inflammation of the joints. Clinically, degeneration of the joints does not produce redness or warmth except in rare cases. In inflammatory arthritis, there is warmth, redness, tenderness, and swelling in the joint. Arthritis versus synovitis. In arthritis, the patient has pain throughout the range of movement of the joint, while in synovitis, pain is only at the extremes of movement. It is important to distinguish between the two as approach to the patient is different in each case. Which joints can be involved? In the upper limb, the shoulders, elbows, wrists, small joints of the hand can be involved. In the lower limb, hips, knees, ankles, small bones of the feet can be involved. In the spine, facet joints can be involved. And in the face, temporomandibular joints can be involved. Osteoarthritis. This is a degenerative condition of the joint. The common joints involved are the base of the thumb, distal interphalangeal joints, knees, and hips. Risk factors include obesity, injury, repeated stress to the joint, female gender, and bone deformities. Progression of diseases associated with vitamin D deficiency. Treatment includes rest, physiotherapy for strengthening muscles around the joint, reduction of weight, treatment of vitamin D deficiency, kneecaps, and joint replacement for hip and knee if severe. Inflammatory arthritis. Causes include seropositive, which is rheumatoid arthritis, SLE, scleroderma, vasculitis, and Sjogren's syndrome. Seronegative arthritis, which is ankylosing spondylitis, psoriatic arthritis, reactive arthritis, inflammatory bowel disease, arthritis. Infectious causes are viral, like dengue, bacterial, like staphylococcus, tuberculosis, and fungal. Crystal-induced include gout and pseudogout, also called calcium pyrophosphate arthropathy. The classic history in inflammatory arthritis is morning stiffness of more than 1 hour duration. The pain is worse at rest and it's better on movement, while the classic history in osteoarthritis is that the pain is increased on exertion and it's better at rest. It's short-lasting. The morning stiffness is short-lasting if it is present. Lab tests in inflammatory arthritis include ESR, CRP, complete blood count, which shows either a high WBC count or a high platelet count, or it could be normal. Rheumatoid factor, which is not a specific test for rheumatoid arthritis but can also be found in other conditions. Anti-CCP antibody, which is highly sensitive for rheumatoid arthritis. ANA, which can be positive in SLE and other inflammatory conditions. dsDNA, single-stranded RNA, are highly specific for SLE. HLA-B27 is a marker for ankylosing spondylitis. P-ANCA, C-ANCA are markers for vasculitis. Rheumatoid arthritis is the most common cause of inflammatory arthritis and occurs more frequently in middle-aged women. We cannot diagnose rheumatoid arthritis until the history of arthritis is of more than 6 weeks duration. The arthritis is usually severe and involves the hand joints of both sides. Many joint groups can be involved, and the arthritis is symmetric. There is notable stiffness in the involved joints in the morning. The patient can have nodules under the skin of the elbow. They can have a red eye due to scleritis or uveitis. Lung involvement causing breathing difficulty, including Kaplan syndrome, and cardiac involvement causing heart rhythm abnormalities and fluid collections around the heart. People with rheumatoid arthritis have an increased risk for heart attacks. Rheumatoid factor test is done for the severity of the disease and need not be positive in this disease. Anti-CCP antibody is a test which can detect rheumatoid arthritis early and even a few years before the actual manifestation of the disease. Treatment of rheumatoid arthritis includes combination therapy with drugs that alter the immune system, like methotrexate and leflunomide. Steroids are used for acute flares of the disease, but are better not given on a long-term basis. It has been proved that starting disease-modifying drugs like methotrexate earlier rather than later has a marked effect on the outcome of the disease. Delay in treatment causes permanent crippling joint deformities. Systemic lupus erythematosis is a disease which is also more common in women than in men and is usually seen in women of the childbearing age group. While joint pain or joint inflammation is one of the conditions associated with SLE, the disease is characterized by involvement of the nervous system, blood cells, and skin as well. The joint inflammation SLE does not cause deformity, unlike in rheumatoid arthritis. The patient may have a butterfly-shaped rash on her face, depression, seizures, anemia, low WBC count, low platelet count, burning of the skin on sunlight exposure, and kidney involvement causing nephritis and eventually kidney failure. ANA, dsDNA, single-stranded RNA are the blood tests to diagnose the condition, but sometimes blood tests are inconclusive, while kidney biopsy reveals the disease in patients with kidney involvement. These patients are prone to have clotting problems due to antiphospholipid antibody syndrome. Treatment of SLE is with hydroxychloroquine for joint disease, immunosuppressants like mycophenolate for kidney disease, and cyclophosphamide for brain involvement. Anticoagulation is indicated if evidence of antiphospholipid antibody syndrome. Reactive arthritis is an inflammatory arthritis which occurs after the evidence of an infection, either urinary or a gastrointestinal infection. The condition was earlier called Rita syndrome. The classic triad is a non-infectious urethritis in which the patient has a urethral discharge or a burning urine with a sterile urine culture, arthritis and conjunctivitis. This combination is only seen in 1/3 of the patients. HLA-B27 is positive in some patients. The treatment consists of painkiller medicines like ibuprofen, and if chronic or not responding to painkillers, immunity-suppressing medicines like methotrexate and sulfasalazine. Antibiotics are indicated if there is an evidence of ongoing infection. Gout is a condition more often seen in men and in those consuming a large amount of alcohol or red meat. It occurs due to the deposition of uric acid crystals in the joints of the large toe and less often in the knee and ankle. The patient has sudden onset excruciating pain in the joint with redness and warmth. Serum uric acid levels do not correlate with the activity of the disease. It is also harmful to lower uric acid abruptly with medicines like febuxostat and allopurinol. X-ray in acute gout may be normal. Calcified tophi may be seen near the joint in recurrent or chronic disease. Joint aspiration shows diagnostic negatively birefringent crystals or uric acid. Treatment consists of colchicine and NSAIDs. Alcohol should be avoided, and after the acute episode subsides, uric acid lowering medicines may be prescribed if the patient has a high uric acid. Ankylosing spondylitis is an inflammatory condition involving the spine and sacroiliac joints, mostly seen in men aged 20 to 40 years. It is a progressive disease that is debilitating and eventually results in fusion of the joints of the spine, causing difficulty in breathing due to the inability to take in a full breath. The patient starts with having pain in the buttocks, worse at night, and this goes on to involve the lower back. Arthritis in the joints of the upper and lower limbs also occur, but less frequently. While X-ray may pick up findings only later in the disease, MRI is a better test to detect the disease early, along with HLA-B27. The patient can have a red eye on and off due to uveitis. Cardiac involvement results in aortic regurgitation in 1/5 of the patients. Treatment consists of indomethacin and early administration of immunomodulating drugs like infliximab. Does vitamin D deficiency cause arthritis? It has been shown that vitamin D deficiency cannot be linked to the cause of arthritis directly, the progression of osteoarthritis is much faster in those with vitamin D deficiency than in those with normal blood levels of the vitamin. Therefore, it is wise to do a vitamin D level in those patients suffering from osteoarthritis and supplement them if needed.